left bundle branch block, wide QRS of 120 milliseconds or more, absence of Q wave in lead 1, V5 and V6, R wave broad notched or slurred R wave in 1 AVL, V5, V6, STT changes that are opposite to QRS direction, and S wave, deep broad S wave in lead V1 and V2, ST elevation in V1 to V3 and T inversion in lead V5, V6, 1 and AVL. Incomplete left bundle branch block with typical features of morphology and QRS duration less than 120 seconds. Causes are, it can be MI or ischemic heart disease or aortic stenosis or hypertension. Incomplete right bundle branch block characterized by QRS duration between 100 and 120 milliseconds. Other findings are RSR pattern in V1 and V2, a wide R deflection than the initial R wave, a prolonged S wave in lead 1 and V6. Incomplete RBB is most common findings on ECG and doesn't require any evaluation if systemic examination is normal. But if there is chest pain, we have to do troponin and evaluate by echo. If QRS duration is greater than 120 milliseconds, RSR pattern in V1 to V3 with slurred S waves in lead 1 AVL and frequently V5 and V6. Left ventricular hypertrophy. If the myocardium is hypertrophied, amplitude of QRS representing ventricular depolarization is increased. It can be LVH with QRS widening or LVH with left ventricular strain, which is repolarization abnormality. We have to differentiate between ischemic heart disease with this. R wave in AVL and S wave in V3. If the sum is more than 28 mm in males and 20 mm in females, LVH is diagnostic. In lead 2, 3 and AVF, there is a deep T wave inversion along with a slight ST elevation. So we have to treat it as ACS and give stat medicine and refer to cardiology. There they underwent a stent operation and followed up good. ST segment elevation in V1, V2, V3 and V4, it is acute MI. So 2-3 AVF is inferior wall MI with reciprocal changes in the chest leads. Benign early repolarization, ST elevation in the V2 to V5 with no reciprocal changes, no convex ST segment and no pathological Q wave, no acute evolution, no clinical signs and symptoms, almost associated with short QT interval, maybe notch J point. J point elevation of 1 mm or more, if it is there, it is ST segment elevation, but don't compare J point to the PR segment. There are medical conditions which may cause PR interval depression. ST elevation MI evolution changes include and T inversions and widespread T wave inversion also suggest ischemic heart disease, and ST morphology in pericarditis is concavity upwards and left ventricular aneurysm and Brugada syndrome also mimic the MI. Anteroseptal MI, ST elevation V1 to V4 with reciprocal ST depression in 2-3 and AVF. Next is anterolateral MI, ST elevation V1 to V3, 1 and AVL, reciprocal ST depression in 2-3 and AVF. Next is lateral wall MI, ST elevation V4, V5, V6, 1 and AVL and reciprocal ST depressions in lead 3. Culprit is LCX. Inferior wall MI, ST elevation 2-3 AVF and reciprocal changes in 1 and AVL. Culprit is RCA. Posterior wall MI is manifested by ST depression and upright T waves in V1 and V2 just opposite to MI. So it is difficult to diagnose. In V1 and V2 there is particular features. Posterior wall MI need V7 to V9 leads and it can be associated with inferior wall MI or isolated. Ventricular fibrillation is complicated of ST-MI and tachycardia also is a complication. Whelan syndrome is critical stenosis of LAD. Proximal LAD near occlusion is Whelan syndrome. Pericarditis diffuse non-localized ST elevation in all leads except 1 and AVR. Brugada syndrome can mimic the T wave inversion in MI. And next is Wolff-Parkinson-White syndrome. Hyperkalemia, initial sign is hyperacute T wave, later QRS and T start to widen and appear as ST elevation MI. Left anterior fascicular block, left axis deviation with 2-3 AVF are negative and lead 1 and AVL are positive. RS complex in lead 2-3 and AVF with small R wave and deep S wave, and QR complex in lead 1 and AVL with small Q wave and tall R wave. There is left axis deviation. In hypertension, there is amplitude of QRS is increase in the ECG.